Hi, I'm Ehsan Zafar from Division of Pulmonary and Critical Care. I'll be talking about documenting ongoing improvement and PDSAs in a way that makes it easy to disseminate and publish. As an academic institute, we all should aspire to publish our work so others can benefit from our learning as well. Think about this. The problems you're trying to solve in your QI project are surely bothering someone else in the world. And if you had a clear pathway of what to do and what works, it would have helped you as well. Let's start with a question. How many PDSAs have you done so far? How well did you document them? 6 to 8 months from now, will you be able to look back at your documentation and tell what you did exactly and what you learned? This will be helpful to describe your journey and knowledge. So here is how I see things. If a tadpole looks at a frog, it will wonder, how did you get there? When did you get rid of this tail? When did you start jumping instead of gliding? And when did you start talking and saying, ribbit, ribbit? So our situation is no different. You are here right now. You are in the early stages of learning improvement science and implementing and driving the change in the system. And I'm no better than you, just a little ahead in QI experience. So all of you are going to be a frog one day, as long as you don't mutate or you die in the process, which means give up on QI. In the next few slides, I'm going to share with you my presentation at the end of my project work, and I presented this work at IHI. My project was about COPD readmissions. COPD is a chronic and progressive lung disease. It's a global problem, and in the US, it is the third leading cause of death, killing more people than breast cancer and diabetes combined. COPD exacerbations are acute episodes of flare-ups that have devastating effect on patient quality of life, disease course, mortality, and has a very high healthcare cost. So why do COPD readmissions matter? Well, in the US, we have a large number of hospitalizations for COPD exacerbation, and more alarmingly, 1 in 5 people leaving the hospital get readmitted within 30 days of discharge. However, the rates of readmission differ widely among hospitals. As we can see on this histogram, the 30-day risk-adjusted readmission rate can vary from 15% to 28% depending on which hospital you end up going to. So given this variation, that suggests a role of system-level factors. COPD was made part of the hospital readmission reduction program in 2014. However, reducing COPD readmissions in real life remains a challenge. So the context of our project is University of Cincinnati Medical Center, which is an 800-bed academic safety net hospital. Almost all COPD exacerbation patients are taken care of by internal medicine teams. Majority of the patients are admitted through ER, and a small portion are transferred from outside hospitals or the medical ICU. The medicine teams were non-geographic at the time when we started the project, so a COPD patient could end up on any of the 6 medicine floors on any of the team. Each team member has an attending, 2 to 3 residents, and they are assigned a pharmacist and a care coordinator. Our objectives were twofold. First, we wanted to identify failures in care delivery and develop a context-specific COPD care bundle that would mitigate most of the failures. Second, using Model for Improvement, we wanted a reliable implementation of bundle to achieve 90% adherence. In this way, we wanted to test our hypothesis that mitigating system-level errors through reliable care delivery will reduce COPD readmissions. At baseline, we had high COPD readmission rate. In this control P chart, we have time on x-axis in months, and on y-axis is readmission rate. As you can see, for the last 2 years, we had a stable system with common cause variation only and a mean readmission rate of 22.7%. So we were dealing with a stably bad system with common cause variation only. Since the system has been stable, we sampled patient charts for 6-month period. We studied patient variables, quality of care, and system-level failures. In this sample period, there were 207 index admissions for COPD and 44 all-cause readmissions. COPD was the most common cause for coming back to the hospital and getting readmitted, and the median time to readmission was 7 days, whereas the median time to follow-up appointments was 9.5 days. This is a Pareto analysis of identifying failures in care delivery at discharge from the hospital. As you can see, the high-yield failures included suboptimal COPD medication regimen at discharge, which means medicines were not as per evidence base, late or no follow-up appointment, lack of an emergency plan, and so on. This helped us identify high-yield opportunities for designing our COPD care bundle. We understand that chart reviews may not give the complete picture of patient experience and failures, so we interviewed patients who were readmitted and asked them simple questions like, how was your experience after you left the hospital last time? What led you to come back to the hospital? And how we could have done it differently. Some of the problems that surfaced from these interviews was that there is a complete confusion about inhalers. There are different brands of inhalers out there and different colors of inhalers with different techniques of use. When the patients are in the hospital, they get certain brands of inhalers based on the hospital formulary, and typically they get used to that when they're in the hospital. But when they are leaving the hospital, they get the insurance compatible brands, which may be very different from what they use in the hospital. Patients also reported ambiguity around who to call for any help after they are discharged, and sometimes they also had insufficient supplies of medications. So this is the structure of our team. We had physicians from hospitalist team, we had respiratory therapists, bedside nurses, and managerial level nurses, pharmacists, care coordinators, all helping in the team project, and I was a team leader. And I would also access ad hoc members for the team that included EMR support, data support, and other content experts. Next step was to develop the COPD care bundle. So we formed a multidisciplinary team that I just showed you that were tasked to develop this bundle that would mitigate majority of the care delivery failures. They were informed by the system failures through chart reviews, unmet needs of the patient through interviews, and evidence-based from literature review. The number of bundle elements was limited to 5 to make sure that we pick the high-yield components that are applicable to most patients. Different ideas for bundle elements were discussed before finalizing these 5 elements, which are to give appropriate inhaler regimen at discharge, which is evidence-based, give a 30-day supply of insurance-compatible brands of the inhalers in hand as people are leaving the hospital, give them personalized inhaler education, have a follow-up appointment within 15 days, and give standardized discharge instructions. Our outcome measure was 30-day all-cause COPD readmission rate, and our process measures were adherence to COPD care bundle components and adherence to individual bundle component, and we also kept an eye on the length of stay for the hospital as a balancing measure to make sure that we're not causing delays in hospital discharge. One of the first steps in understanding the existing system is to walk through the system in the shoes of the end user. And this is how I mapped out the process map of the existing system. That the patient gets identified by physicians and they put in the orders for inhalers while the patients are in the hospital. The inhalers are changed to formulary of the hospitals by pharmacy. The respiratory therapist delivered the inhaler medications to the patients and typically teach them about those inhalers as they're giving them those medications. Care coordinators would evaluate patients if they were high risk and then arrange follow-up when they were asked about. And then many activities are kept for the day of discharge, which includes physicians prescribing the discharge inhalers, pharmacy trying to figure out what is insurance compatible so they could arrange those brands for the patients, and then the discharge instructions are written by the physicians and read by the nurse. And patient may leave with supply of inhaler in hand or at times would leave without a supply in hand. Clearly, this system is poorly designed, and no one in their right mind would design a system like this. Each of these individuals, the respiratory therapists, the pharmacists, the physicians, they could be best at their job, but they would still fail the patient because the system is broken and people are not working towards the common goal. This respiratory therapist could be the best one in the world, but they're still giving them education about the wrong inhalers which patients will not take with them at home. Clearly, many problems here. There are unclear roles and expectations, lack of tools and information to deliver expected care, and teams are not familiar with the role of each other. There's interrupted information flow, and many things are kept for the day of discharge, creating a bottleneck. So our smart aim was to improve the bundle adherence to 90% for all patients admitted with COPD exacerbations, and here are key drivers. We wanted early, reliable activation of the bundle, clear communication and role assignment, standardization of processes and tools, staff buy-in and staff training, and timely completion of the bundle, making it very lean. So now we are thinking of system redesign. But where to start? So first thing was an idealized state. We all got together again and said, if you want to deliver these 5 elements of the bundle, what could an ideal system look like? And we put together this proposed process map. Using this as a template for our PDSA testing, we now started testing each of these boxes and their connections with other boxes. Now I'll walk you through our interrupted time series analysis for process improvement. This will be a control P chart with time in weeks on the x-axis and percentage of the bundle components that were completed that week on the y-axis. Our goal was to achieve 90% adherence. In the early testing, we explored the role and feasibility of multiple new processes. Our testing included frontline staff for physicians, pharmacists, nurses, care coordinators, and respiratory therapists. We explored how patients could be identified, how pharmacy could identify insurance-compatible brands early, right after admission, how we could arrange a 30-day med supply, and how inhaler education could be provided. During these tests, we developed new tools, new note templates, and the EMR and communication methods for improved information flow. Here's an example of a note developed by pharmacy that identifies discharge inhalers, their brands, and communicates it to the rest of the team. The RTs use this information to educate the inhaler use using newly developed handouts that were easy to understand and using inhaler education kits with lots of dummy inhalers for practice. Next, as the individual processes were getting better, we wanted to see how different components could work together as a bundle. When would the bundle be activated? What information needs to be communicated to which team and how much? And how could this be reliably performed? So I started off with a fake front-end test, which means that we faked existence of a service that did not exist. A bundle was activated using emails and text messages whenever there was a COPD patient on a medicine team identified. This helped us understand when bundles should be activated, what will be the roles and communications to each team, and what is reasonable turnaround time for each process. During this time, we continued our ramps of improving the individual processes and upscale the testing. This phase helped our whole team increase our degree of belief and also attain buy-in from the frontline staff. With this knowledge, we then went to EMR and developed the COPD care bundle as an order set. This was to be activated on all admitted COPD exacerbation patients as soon as they were admitted to a medicine team. We had observed 2 shifts in the process measure. By this time, the processes were standardized and were spread to all days of the week. Each team developed staff training modules and methods, and almost all existing staff members were trained. The one thing that we constantly struggled was to get the physicians to write standardized discharge instructions, and we were trying different ways to overcome that challenge when one of the team members from the respiratory therapist said that they could just provide the standardized discharge instructions while they were giving inhaler education. So this provoked this idea of developing my COPD care sheet that respiratory therapists would go over with the patients and teach them what they need while they're in the hospital, what are their discharge medications, what would be their COPD emergency action plan at home, and how can they better prepare for follow-up clinic visit. Once all processes were finalized, we created an EMR best practice alert to increase the reliability of the bundle activation and all the processes that come after that. The adherence to the bundle components then reached 90% and has been sustained. After thorough testing and redesign, this is how the new process map looks like. Much leaner and much better than the one that we proposed initially, as we learned so much from the PDSA testing and continue to refine this. We purposely built high reliability processes upstream so that the downstream processes don't fail. We added deliberate redundancy to some of the processes to increase the reliability. So multiple teams are doing things in parallel, and failure of one team does not necessitate failure of the next team. You can also observe that we got rid of the nursing checklist process in the end, since all items become much more reliable and performing the checklist itself was unreliable. Coming to our outcome measure, we saw a system shift with reduction in COPD readmissions from 22.7% to 14.7%, which is more than a 30% drop. The evidence-based medicine is now become a system property rather than individual responsibility, and we were able to show that mitigating system failures reduce COPD readmissions. Furthermore, we observed a dose effect. Patients who received all 5 components of the bundle had a readmission rate of 10.9%, those who missed one component had a rate of 12.9%, and those who missed 2 or more components still had high readmission rate. This increases our degree of belief that it is the bundle that led to the readmission reduction. So this was my presentation at IHI 4 months after my 6-month course was completed.
This is it. This is the answer. It says here that a bolt of lightning is going to strike the clock tower at precisely 10:04 p.m. next Saturday night. If we could somehow harness this lightning, channel it into the flux capacitor, it just might work. Next Saturday night, we're sending you back to the future.
So these were my slides from IHI presentation 4 months after completing my course. Now let's see how things look like while in the midst of the work. The slides from now onwards are from my master slide deck, which I used as my project notes and kept updating every 2 weeks. So I saved the file every 2 weeks, kept that as archive, and continued working on the current deck. This helped me keep a track of the progress and gave me an ability to look back in time and also pull out the slides in need for any specific meeting, occasion, or sharing an idea. So let's go back and see how things were at session 5 of my project work. This was the status of our bundle adherence, which is our process measure. We had 1 shift so far and we're heading close to the 2nd shift. As you can see, there's a lot of testing going on and we were using multiple PDSA ramps simultaneously. Here's the line chart for each of the 5 individual bundle components. So what do you see in the first look? It's a scatter. Essentially, it's all over the place. You can see that the pharmacy-related processes of appropriate discharge medications and 30-day med supply quickly became reliable because it's a small team and we moved through testing and implementation much faster. However, for other processes, it was a scatter. Lots of learning PDSAs to figure out how to make it work and what works best, and then moving to staff training and training multiple team members. For example, there are 104 respiratory therapists who needed to be trained. So those processes are lagging behind, but we had developed enough theory that we knew that we were heading in the right direction. As you can see, I was managing multiple PDSA RAMs and multiple teams at the same time. So keeping it organized was very important for me and for the teamwork. This is a tool that I use to capture information of who is responsible for a key critical step in the bundle delivery. So we can identify using this tool that who is the primary responsible team for identifying COPD patients and doing the testing in that space, who is responsible for personalized inhaler education, and so on and so forth. This tool also helped the teams stay focused on their aspect of the work without worrying too much of what's going on in the whole system. For example, when working with the pharmacy team, I would just jump to the slides that are relevant to that team. And here you can see the pharmacy is responsible for 2 critical roles: appropriate discharge inhalers and their insurance-compatible brands, and arranging a 30-day supply before the time of discharge for those brands of inhalers. These are the failure modes specific to the pharmacy process only and what that team is learning, so we can focus on their learning specifically and what are the modifications needed to address the hurdles in their process. And then here is a detailed process map for the pharmacy team itself, that what they actually do to get this thing done. So this way, when I'm meeting with the pharmacists, I could focus on their processes in much more detail and refine it with their own ideas and their learnings. So now let's take a look at the PDSA ramp of the pharmacy process. As you can see, these slides are really old. Not that old though, it's like 2015, but they look really old. They look like 1980s with the colors and with the design. Let's walk through this ramp so you can see how we were moving from very small test of change all the way towards implementation. So our test one is how the inpatient pharmacy can communicate with the outpatient pharmacy to figure out insurance compatible brands of inhalers. So it started off with one patient, one inpatient pharmacist, and one outpatient pharmacist. The only thing we were testing over here is to see what are the pieces of information that needs to be exchanged from inpatient side to the outpatient to be able to identify what is insurance compatible for that specific patient who's in the hospital. From this, we moved on to the test 2. Now it's 2 patients, 2 inpatient pharmacists, and 1 outpatient pharmacist. And I helped them identify the patient. We learned more, found out new failure modes, and modified the process further. Next, we wanted to see if this new modified process could work for high patient volumes. Is it lean enough? Could it be done quickly? Or does it take too much time? So I was identifying the patients for the team and acting as if the bundle is activated by sending them a text message or an email. In this particular day, we had 7 referrals and were able to complete the process on 6 of them. Now we spread it to all inpatient pharmacists and outpatient pharmacy techs. During these tests, the team developed standardized note for clear communication. As you can see now, they are mentioning that what will be their insurance compatible brands for this particular patient to take home so that the inhaler education can be given accordingly, and they have started to work on arranging a 30-day supply for the patient. Now we moved on to all inpatient and outpatient pharmacy team members and all weekdays, which require training of staff members with a goal turnaround time to have the note placed in within 24 hours of bundle activation. And then comes a drum roll. In test 6, the process was now shifted to the new epic order set. As you can see, we did not jump to the epic change right away until we had learned enough what exactly is needed to build that bundle order set. And one of the comments from an epic builder was that this is the first order set that he had built that did not require any modification or changes after it was developed. Then in the last 2 steps, the process is now spread to all days of the week and holidays included. The pharmacy team developed training modules for new people coming on the team and developed a standard process for implementation. And here's the performance of pharmacy-specific processes, which were the 2 bundle elements that achieved high reliability much earlier than all other bundle elements. Now let's quickly walk through an example for the RT process. So when I'm talking to respiratory therapist, we are now focusing on these 2 elements that are under their direct responsibility, which is delivering a personalized inhaler education at bedside, and then the added on responsibility was to teach people about standardized discharge instructions at the same time and giving inhaler education. Before doing any testing, we started off with brainstorming ideas that how will this education be conducted at bedside, what needs to be included in it, and how can we standardize the process that all RTs can follow the same steps, and how can we track that inhaler education was done or not. So during this time, we developed new inhaler education handouts, which are grade 6 readability and understandability. Every inhaler type has its own handout, and these are all made by our own team. And of course, as you can imagine, many of these handouts went through multiple revisions after we learned from PDSA cycles that what needs to be modified. We also developed a standardized note by the respiratory therapist, which is a dot phrase, and the RTs have to go through each and every step by clicking was this step performed or not. So essentially this note serves as one, a checkpoint for us to know in a chart review if this inhaler education was performed or not, and second, even if the RT does not remember the step of what to do, putting in the note, they can walk through the steps and see what they needed to do. So this was an educational tool plus an adherence measuring tool. And here's my documentation of the RT inhaler education ramp, starting off with small test of change, learning a lot from them, and then moving forward. It was really exciting to see the enthusiasm that artists brought to this process. Initially, we thought the pharmacy would give the supply of inhaler for discharge in the patient room, and artists can use those inhalers to teach them. But unexpectedly, we saw that many times patients would send the inhalers with their family at home already, so artists would be in the room without any sample inhalers to practice. So, this led to the idea that we need to develop inhaler education kits which hold all the handouts, which has a step-by-step guide how to use the kit, and has a collection of different types of inhalers that are available in the market to let people touch them and practice and see how they would work. And by this time in the project, inhaler education adherence was like stock market, up and down and crashing at times, but we kind of learned the process of what works, and by this time we knew what exactly we need to teach, spread, and implement. So it's kind of an expected performance. But of course, it's disheartening to see zero adherence at times. So this is how I maintained my organization for conducting multiple ramps and managing multiple teams. I won't go over the details of the next of the slides, but just wanted to show that how I kept my notes organized. Having a running slide deck like this helped me not worry about where did I write something or if I'm going to lose any information later on when I'm sitting down and writing my project or narrating my project in the manuscript. And as you remember, the nursing initiative was something that we abandoned eventually because our other processes became more reliable and we did not need the nurses to be doing any specific part of the bundle. So this saved us a lot of time because to train hundreds of nurses to get a process done on a patient who could end up on any of their shift was very difficult. At the time of my presentation in session number 5, this is where we were in our outcome measure. So we had no changes yet. It's all common cause. But, we're seeing 4 dots below the red line. And although there's no time to celebrate this, and we know we should not celebrate this, but you start baking a pizza in your heart already. And, you won't take it out to the party right now, but it's something is cooking. So hopeful, but not celebrating right now or not showing the celebration on the face right now. Okay, now let's take a pause and reflect on a few things. Was this helpful for you to see how you could keep your notes and organize them as your process is going on and you're dealing with multiple teams and multiple interventions at the same time? Also, how could this be done differently? And how are you capturing the learning that you are getting through your testing phase? Now that you have seen all the behind the scenes work, I will show you how the PDSA ramps were described in this publication. Reliable adherence to COPD care bundle mitigates system-level failures and reduces COPD readmissions, a system redesign using improvement science. It was published in BMJ Quality and Safety Journal in 2017, and I would like to acknowledge all the authors, team members, mentors, patients, and frontline staff for their contribution in the system redesign, which now produces better outcomes. And before I show how I documented the PDSAs in this paper, let's see what the Squire 2 guidelines say about it. Squire 2 is the format that we use for QI publications, and all journals will ask you to follow this pattern if you have a QI project that you're trying to publish. I highly recommend you reading the Squire 2 guidelines as they're not only telling you how to write a paper, but each section will walk you through the right steps and tell you the things that you need to consider in your improvement journey for that particular step. So let's see under the methods section what it says. Under intervention, it says the description of the intervention should be in sufficient detail that it could be reproduced by others, and the specifics of the team involved should also be mentioned. And then in the results section, they want us to describe the initial steps of interventions and the evolution of the intervention over time and the modifications we made during the course of the project. And they would like to learn about the unintended consequences of our interventions. So what they're telling us is that describe our improvement journey, the continuous improvement phase of PDSA cycles in sufficient detail that people can benefit from your learning. In our paper, I provided a reasonably detailed account of PDSA ramps in the online supplement. In this table, we described what are the intervention that was being tested, what was the summary of the plan, do, study, act cycles, and what were the outcomes, the challenges, and the final act of that particular intervention. And then I've classified them in multiple categories. So the first process we talk about is how do we reliably identify patients and timely activate the COPD care bundle. In this, we had multiple ramps that included role of bedside nurses, which we did 3 PDSA cycles and eventually the process was abandoned. We also did physician training in COPD care bundle use and build the EMR order set and the BPA. Those 2 processes were implemented. The next process is about early identification of insurance compatible inhalers and so on and so forth. So I mentioned the number of PDSAs done for that particular ramp, and I also mentioned the level of reliability achieved by the end of the project for that particular process. And here are some success tips that I would like to share with you. Keep a record of your PDSA cycles in as much detail as pragmatically possible, because it could be hard to capture every little bit of detail if you are doing multiple PDSA cycles. So whatever is pragmatically possible, especially your theory of the PDSA cycle, what you learned from it, and what you're going to do next is very important. This documentation of continuous improvement phase and PDSA cycles is like your lab notes for a QI manuscript. Also, capture each learning. Do not waste it. It will help you in the current project, and also when you move from your current project to spreading it to other places within the hospital or outside. This learning can help you anticipate failures and mitigate them before they even happen. In the end, I would like to encourage all of you to do your project in a way that you are going to publish it and disseminate it. Believe me, it is very gratifying to see the improvement work and the learnings you did in your context, helping other places, hospitals, and patients get better care because of what you had disseminated. With that, let's take a pause for some discussion. Thank you so much for listening, and I hope you enjoyed the talk.